Dr. Thamm, can you hear me?
Yes.
Thank you very much for much collaboration with us. If you feel free, you can start.
Okay. Thank you very much. I'm going to talk and begin to share my screen at the same time. So I hope that this is okay. Okay. Can you see my slides? Anybody?
Yes, we can see.
Very good. Thank you. So I first must apologize for not being able to attend your Congress in person. I very much love visiting Brazil, and it would have been wonderful if I had an opportunity to be there in person. But thankfully, technology allows us to also give lectures like this remotely. So when I was chatting with Nazilton about topics for a lecture, he mentioned that Nouvet is very interested in potentially becoming a center for clinical research in veterinary oncology. And here at Colorado State University, oncology clinical research is something that we have done for a very long time. So he thought it might be good if I could give a brief introduction to our center and specifically our clinical trials service, and then provide a few examples of some studies that we have recently completed here at Colorado State. And these happen to be all studies that are involving dogs, but we certainly also do feline research as well. Conflict of interest for this hour, the one conflict that is relevant is I'm a shareholder in a company called Calviri, and Calviri is working to develop a vaccine that I will talk about today. So some of the things that we'll talk about include, again, an introduction to the oncology service here at Colorado State University, and specifically the team that performs clinical trials. Then I'll give you 3 different examples of studies that we have recently completed, including a new chemotherapy protocol for the treatment of canine lymphoma that we evaluated, a study from my colleagues, Drs. Steve Dow and Daniel Regan, looking at repurposing the blood pressure drug losartan as an osteosarcoma treatment. And then finally, a very large study that we recently completed that's evaluating a vaccine approach that might be useful for the prevention rather than the treatment of cancer in dogs. So just a little bit of information about our clinical service at the Flint Animal Cancer Center here at Colorado State University. So our center sees approximately 1,800 new patients per year. And this represents almost 30% of all of the small animal cases that are seen in our entire hospital. So that's all the different small animal specialties. And we also see about 4,000 rechecks per year. Our cases are very, very heavily towards dogs. About 85% of our patients are dogs, while only 15% are cats. And you can see a list of some of the cancers that we see with some frequency and how often we see them. So we have been known for many decades as a sort of a specialty center for osteosarcoma research. So we probably see more osteosarcoma than many other sites do. And then again, you can see a list of other tumor types that we see with some frequency. It's probably not too different from the tumors that you see in your practice as well. One notable difference, of course, is that in our practice, we see very few mammary tumors because of the practice of early spaying here in the United States. So talking about our clinical team in general, this is not just for clinical trials, but the entire team for the Cancer Center. we have 3 surgical oncology faculty, 2 surgical oncology fellows, 5 medical oncology faculty with 6 residents and 1 intern. We have a little bit more than 2 radiation oncology faculty and 4 residents. And then there are 11 technicians, if you include the technicians that work for medical oncology, surgical oncology, and radiation oncology. So this does not include the technicians that work for clinical trials, which I'll mention. For the past maybe 2 years or so, we have also had maybe 10 or so undergraduate students who are interested in pursuing veterinary school in the future, who work as assistants in our clinic, and they have become a very valuable part of our team. And then we have 2.5 full-time coordinators who help with appointment scheduling, communication with clients, communications with referring veterinarians, and coordinating our very busy consultation service that we offer, which is free for both pet owners and for veterinarians who have questions about cancer. The clinical trials team specifically is a group of patients here who only see oncology patients who are participating in studies. So they have no other responsibilities in our center. And this includes 1 full-time faculty member who is board certified in medical oncology and whose only job is to supervise the clinical trials team. This is Dr. Weishart here. Then we have 3 full-time technicians. This is Chris, Danielle, and Lisa, and a full-time coordinator who actually has a master's degree in biotechnology and has 25 years of experience both in human clinical trials and in human laboratory practice. Then we also have an intern who is a veterinarian whose job is only to work with the patients on the clinical trial service. And then at any time, one of our 6 medical oncology residents is also rotating through the clinical trial service and only seeing clinical trials patients for that period of time. And the types of studies that we do are quite broad, including chemotherapy, targeted agents, immunotherapy, radiation therapy, imaging studies, as well as studies evaluating novel devices or novel surgical techniques. Just some statistics from 2024. So last year, during all of that year, we had a total of 26 clinical trials that were ongoing for at least part of the year. And again, in 2024, in addition to seeing, again, a total of 700 appointments, the Oncology Clinical Trials Service saw 91 new patients. So these are patients that were referred from outside of the university specifically for participation in a clinical trial. Most of the other patients that we enroll in our studies are seen by our main clinical service at the Cancer Center, and then our clinical trial service will consult as part of that patient's comprehensive evaluation, and clinical trials may be offered for those patients. So with that very brief introduction, I want to very quickly just discuss 3 different clinical trials that we have finished recently in dogs with cancer here at the Flint Animal Cancer Center. And the first one that I'll mention is a study that we actually reported at last year's Veterinary Cancer Society meeting, which is a clinical protocol for the treatment of canine lymphoma that we refer to as the APPLE protocol. And again, this uses the drugs asparaginase, procarbazine, prednisone, and lomustine. And this is meant to be a first treatment for previously untreated dogs with lymphoma. And I'll explain to you why we decided to undertake this study as we go. I also should acknowledge funding for this was from the American Kennel Club. So we know that lymphoma is a very, very common disease for us to see in dogs. And we also know that the chemotherapy drugs that we have in our arsenal are drugs that we have been using for many decades, and they work fairly well initially. So we expect to see very high response rates to the injectable chemotherapy drugs that we have at our disposal for the treatment of dogs with lymphoma. But we do know that almost all dogs will eventually relapse. One of the things, at least in the United States, that is very, very challenging about treating dogs with lymphoma may be an inability of owners to get care from a specialist. So there are some statistics that I just learned about this week that suggests that maybe 90% of dogs with lymphoma are not treated beyond maybe only prednisone. And part of that reason is due to a lack of specialist access. And one of the reasons that this specialist access is a real barrier to being able to pursue lymphoma therapy for us is that most of the treatments that we are all familiar with for the treatment of canine lymphoma involve injectable cytotoxic drugs. And here in the United States, we are governed by what's called USP 800, which is a series of rules from the federal government that dictate how injectable cytotoxic chemotherapy drugs must be handled in medical situations. And this doesn't only apply to human medicine, but recently, in the past 5 or 10 years, it has now started to apply more directly to veterinary medicine as well. So there can be large fines and other types of penalties for veterinary clinics who might handle injectable chemotherapy drugs in a way that is not consistent with USP 800. So the goal of this study was to try to evaluate a multi-agent chemotherapy protocol for canine lymphoma that did not involve any drugs that required special handling. So perhaps this is a kind of chemotherapy that might be both well tolerated and something that could be performed in a general practice setting in a way that was safe and more effective than perhaps using prednisone by itself. So this study involved dogs with a histologic or a cytologic diagnosis of lymphoma that were previously untreated, that had at least one lymph node that was large enough to repeatably measure, and the dog who was feeling relatively good. So dogs could not have serious elevations in their liver values and had to have relatively normal complete blood counts as well. Again, no previous chemotherapy was allowed, although previous prednisone was okay. And then prior to starting, dogs had blood work, they had chest x-rays, and then they had flow cytometry performed for immunophenotyping, although the results of flow cytometry were not disclosed to our team until after the study was over. We used the standard lymphoma response criteria to assess response, and the standard adverse effect reporting criteria to assess adverse effects. And then again, what we were trying to do was to see if we could come up with a treatment that was better than prednisone. So we knew that it might not be as good as CHOP. We knew that it might not even be as good as single agent doxorubicin. But again, those were not the comparisons we were trying to make, because those types of treatment may not be available to many, many dogs with lymphoma. So what we were trying to do was find a protocol that was better than, again, a 30% likelihood of being alive at 3 months with prednisone alone. And that's data that comes from the study that you see here from Dr. Rasnick. So our hope was that we would find a treatment where at least 55% of dogs were still progression-free after 3 months. And we would consider that to be significantly better than prednisone alone. And we actually made this assessment using a very unique statistical design that allowed us to continually look to see how effective the treatment was and potentially either stop the treatment early if the treatment was not working, or stop the treatment early if it was very obvious that the treatment was working extremely well. So this is the protocol that we used, and it was a variation on the protocol that you see here from 2017 from Thamm et al. That was published in Veterinary and Comparative Oncology that looked at simply lomustine, procarbazine, and prednisolone as a relapse treatment for lymphoma. So we added asparaginase for the first 1 or 2 treatments. And otherwise, our LPP protocol was identical to what was reported by Thamm. So a very simple 4-week protocol, asparaginase and lomustine given at the same time. Procarbazine started as soon after that as the pills arrived from the pharmacy where they were dispensed, and then prednisone for the first 2 weeks of every cycle. And this cycle would be repeated a total of 5 times in animals who had stable disease or better. I'll explain why in a moment, but after a few dogs were enrolled, we actually made a slight change in the protocol so that procarbazine was not started until day 7 instead of day 2 or 3. And you'll see why that is in just a moment. So I'm not going to go through the details of every test that every dog had at every time point, but you can see here these dogs were rechecked initially quite frequently to make sure that treatment was tolerated well. And then once they sort of got through the first 1 or 2 cycles, we would simply see them once every 4 weeks up until that final treatment. And then after that, we would check them monthly if they had experienced a complete response. And just as a reminder, day 84, or that roughly 3-month mark, is really the day that was most important. So if the dogs remained progression-free at day 84, we would call them a responder. And again, for statistical reasons, those responders, the percentage of dogs that were responders, was our primary endpoint for this study. So the Bayesian adaptive design that I mentioned looked like this. So the red line that you see here meant that if at any point our responses were so poor that we ran into that red line, we would stop the trial. If at any point our responses were so good that we hit the green line, we would stop the trial. So that would mean that the drugs seem to be relatively effective. And the nice thing about this design is that, again, it allowed us to potentially stop early, either because of efficacy or because of futility. So we enrolled 30 dogs in this study. You can see their demographic information here, a very typical group of dogs with lymphoma that present to our practice. And you can see also a typical mix of T-cell and B-cell dogs, about 2/3 B-cell, 1/3 T-cell. This was a protocol that was very, very well tolerated. You can see almost all of the adverse events that we observed relative to the GI tract were low grade. Same thing with constitutional signs like lethargy. We saw a small number of dogs that had higher elevations in their liver values, but again, a fairly acceptable number. One of the things that you can see is that there were some patients who developed grade 4 or severe neutropenia. And one of the interesting things about that is actually in the first 8 patients that we treated, where we started the procarbazine as soon as we could after day 0, actually 3 of 8 of those dogs developed a grade 4 neutropenia. And after we saw that, after those 8 patients were treated, that's when we made the change to starting the procarbazine on day 7. And the reason for that was so that we could check their neutrophils before starting the procarbazine to make sure they were okay. But when we did that change, actually, only 1 out of the subsequent 26 dogs that were enrolled developed a grade 4 neutropenia. So the total amount of drug that these dogs received was exactly the same. The only thing that was different was when the procarbazine was started. So a very, very small change. So here's our results as far as efficacy goes. I showed you this before. This is our little Bayesian adaptive graph. And this is what actually happened to our patients. So you can see that we did meet our efficacy target in that more than 55% of dogs were disease-free or progression-free for more than 3 months. So just to break this down a different way, the overall response rate in this study was 93%, and actually 63% of the responses that we observed were complete responses. And the overall median progression-free survival time was 84 days. Those dogs who experienced a complete response had a median progression-free survival of about 5 months. And for those dogs experiencing a partial response, it was about a month. So one of the things that was very, very interesting is that in this very small cohort of dogs, there didn't appear to be any difference in the outcome between those dogs who had B-cell lymphoma and those dogs who had T-cell lymphoma. So I would not make any very strong assumptions or conclusions about this because of the very small number, but it would be very interesting if this was borne out in a larger studies, so that if this was in fact a protocol where B-cell lymphomas and T-cell lymphomas appeared to have an outcome that was relatively the same, that'd be very different from most of the other protocols that we have. There was a difference based on stage, so the few dogs that we had with stage 5 lymphoma did not do quite as well as those dogs with stage 3 or lower lymphoma. But here's the most interesting thing is when you looked at the two different versions of the procarbazine dosing that we did, there was very significant differences in outcome. So there was a significant, statistically significant difference in complete response rate, 100% in the first version of the protocol where the procarbazine was given at the same time versus 50% where the procarbazine was started on day 7. And this actually translated into a really substantial difference in progression-free interval. So about 3 times better for those dogs where the procarbazine was started at the same time. Once again, just to reiterate the difference between these two protocols, exactly the same amount of drug. The only thing that was different was when the procarbazine was started. So in conclusion, this appears to be a relatively well-tolerated protocol that's associated with efficacy that appears to be superior to corticosteroids by itself. Immunophenotype may not be a major determinant of outcome using this protocol, but this really begs to be confirmed in a separate study. And preliminary data suggests there's this strange possible schedule dependence of procarbazine administration. So maybe using the lomustine and the procarbazine at the same time could be synergistic. So there is data in human brain cancer that suggests that this is the case. So in fact, these two drugs, when they are given at the same time, they may work better. So perhaps this is a better way to give these drugs. I think those of us who are oncology specialists might say, oh, well, if only 3 out of 8 dogs developed significant neutropenia and none of them got sick, I didn't mention that, but none of them had fevers or needed to be hospitalized, maybe that's fine. But remember, we're trying to make this a protocol that non-specialists can use. And I think for a non-specialist, that degree of neutropenia would probably be too scary for them. So we are now actually, just this week, we started enrolling another cohort of patients where we are giving the procarbazine and the lomustine at the same time, but we're slightly reducing the dose of the lomustine to see if we can keep that synergistic effect, but reduce the likelihood of seeing severe neutropenia. So more to come about how this new variation of the protocol works. Okay, the next study I'd like to talk to you about again is this work that comes from Dan Regan and Steve Dow, 2 of my colleagues here at the Flint Animal Cancer Center, looking at using the blood pressure drug losartan as a way to block monocytes from getting into tumor tissues and turning into tumor-promoting macrophages. So we certainly know that there are many, many tools in our toolbox for treating the local disease that's associated with osteosarcoma, and these can include things like amputation. In certain situations, limb salvage surgery can be performed. Different forms of radiation therapy can be performed for local control. And we certainly know that chemotherapy does have the ability to delay metastasis development to the lungs, but unfortunately, still about 80% of our patients will eventually develop measurable pulmonary metastasis that will often or usually be the cause of their death. So new treatments to address pulmonary metastasis when it occurs is something that's actually desperately needed both in dogs and in humans with osteosarcoma. So macrophages are actually a very, very important part of the tumor microenvironment. And we do know that not all macrophages are created equal. So when monocytes go from the peripheral blood and get sucked into tumor tissues, they can turn into what are called inflammatory macrophages, which might actually help to stimulate an immune response, might help to actually suppress tumor growth, or they might turn into anti-inflammatory or pro-tumor macrophages that actually support the growth and metastasis and angiogenesis of the tumor and suppress immune responses. And again, the terms that you may see used for these are M1 macrophages being referred to as the pro-inflammatory macrophages, and M2 macrophages being referred to as the anti-inflammatory or pro-tumor macrophages. And we do know that there are lots of different kinds of macrophages out there. It's very much of an oversimplification to talk about only M1 and M2 macrophages, but it's kind of a useful analogy for the purposes of this talk. So there are many different ways, hypothetically, that we could interfere with tumor-associated macrophages to potentially turn off or eliminate some of their tumor-promoting abilities. So one of them might be, can we actually kill them in the tumor tissue? And this is something that's actually been looked at in Dr. Dow's lab using a drug called liposome cladronate, which can kill macrophages in the tissues all over the body. Another way that you could do this is potentially by changing the phenotype of these macrophages in the tissue. So you could do this with checkpoint inhibitors, non-specific immunotherapy, things like that. And then a third strategy might be to see if you can keep those monocytes in the blood from being able to get into the tumor tissue where they have the potential to turn into these tumor-promoting macrophages. And that is sort of the approach that's being used with this drug losartan. So the first paper that looked at this was a paper in vitro and in mice, where Drs. Dow and Regan demonstrated very nicely that high doses of the drug losartan, which again, I think we might be familiar with as a blood pressure drug, are actually capable of interfering with a receptor that's present on monocytes called CCR2. And CCR2 is the receptor for a chemokine that actually is a very, very potent signaler to recruit monocytes into tumor tissue. And if you block CCR2, you may be able to stop that from happening. And the data that I'm showing here just demonstrates that in vitro, you can actually inhibit monocyte migration via CCR2 using high doses of losartan. This was then evaluated in a mouse model. In this case, this is a mouse colon cancer metastasis model. And those mice that were treated with losartan actually had significantly reduced metastasis in their lungs, as well as having reduced monocytes in those lung tumors. So subsequent to that, actually, we performed, and we meaning the cancer center here, performed a clinical trial in dogs with metastatic osteosarcoma looking at a combination of high-dose losartan. So we actually determined that the dose of losartan that was required to actually inhibit monocytes is about 10 times higher than the dose that's used for blood pressure control, or about 10 milligrams per kilo twice a day. So they got that dose of losartan combined with toceranib or palladium. And in this combination study, the overall response rate was about 25% in these dogs with metastatic osteosarcoma, and another 25% of dogs had their disease stabilized for more than 8 weeks. And when we compare these results to a previous prospective study that we performed looking at toceranib or palladium by itself, the results seem to be much more encouraging. So with toceranib alone, we saw no responses, and only about 17% of dogs had stable disease for 8 weeks. So this combination actually looked very encouraging. And again, this is a great example of drug repurposing. So where we can take a drug that's already been approved for a completely different use in both dogs and humans and find a different way to use it, in this case, maybe as an effective cancer therapeutic. So what's currently going on with this combination? So we've recently finished another study that added a third drug to this two-drug combination. That's a drug called ladarixin, which is actually an inhibitor of interleukin-8 receptor. And we've recently finished a study looking at that three-drug combination in dogs with osteosarcoma as well. And perhaps even more excitingly, there is now a human clinical trial that is ongoing in people with metastatic osteosarcoma, looking at a combination of high-dose losartan with a drug called sunitinib. And sunitinib is basically the human version of toceranib. So they're almost identical in their structure. So we would expect them to have very similar effects in the body, whether it's toceranib or sunitinib that's used. So this is a study that's currently going on here in Colorado, as well as one other site in the United States. And we're very keen to see the results of this study as it moves forward. And then the final thing that I'd like to discuss is another trial that we recently completed, the results of which are pending. So the patients are all treated and enrolled, but we're waiting for the statistical analysis. And this is a study that's called the VAX trial, which stands for the Vaccination Against Canine Cancer Study. And this is a collaboration between Arizona State University, who actually sort of did most of the science associated with this, and then 3 veterinary schools around the United States, including University of Wisconsin-Madison, Colorado State University, and the University of California, Davis. And I must acknowledge the funding that we received from what's called the Open Philanthropy Project to actually support this very large and ambitious clinical trial. So why would we consider wanting to look at a vaccine to prevent cancer? The simple reason is that vaccines have probably improved health universally in both animals and in humans more than any other medical advance in history. And however, we know that vaccines against infectious diseases are relatively easy to develop. And the simple reason for that is because infectious diseases are so different from the normal tissues in our bodies that it is very, very easy to wake the immune system up to recognize these infections, whether they're viruses or bacteria, as foreign, and train the immune system to both recognize them and eliminate them. It's much, much, much more challenging to do that with cancer because cancer derives from us. So 99.9% of the antigens in cancer are self-antigens. They're just our regular tissues. So of course our bodies would not recognize them as foreign. And only a very, very, very small percentage of the proteins that are made by a cancer cell are actually foreign or look foreign to the immune system. However, there are a lot of different potential, what are called neoantigens, that are present in cancer. So anytime there's a mutation in the DNA that actually results in a change in a protein sequence, that might be an antigen that could be recognized by the immune system. And that's very exciting. And there's some very interesting personalized vaccine approaches that are being evaluated in human clinical trials. However, the thing that makes this approach very, very challenging to use for a preventative vaccine, so a vaccine not to treat cancer, but to prevent it from occurring in the first place, is that there are very few of these antigens that are conserved between patients, even those patients with the same kind of cancer. So most of the mutations are unique to a given person's cancer and not shared between people, even with the same kind of cancer, which makes it very, very hard to find these neoantigens that you can turn into a vaccine. So the way that my colleague, Dr. Stephen Johnston, looked for antigens that might be more conserved between different cancers is by not looking for mutations in the DNA, but looking for errors in RNA. So I think we all probably remember from our basic biology that sort of DNA is the template, RNA is the carrier, the messenger that translates DNA, and then protein is the final product that actually goes out and sort of does the jobs in the cell. And protein is also, again, where the antigens are formed. So for obvious reasons, DNA replication is actually a very, very, very tightly controlled and tightly regulated process with a very, very low rate of errors. Because anytime an error is induced in the DNA, it's permanent. It's going to continue forever, for the life of that cell and all of those cells' progeny. However, RNA processing is inherently more error-prone. And the reason for this is that RNA is generally very short-lived. So if, once in a while there's a small error in RNA that results in a small difference in a protein, well, that RNA doesn't last for very long. The protein that is made doesn't last for very long. So the consequences to the cells are actually much less dire for an error in RNA processing than there are for an error in DNA replication. And as a result, there are a lot more errors that actually occur in RNA and proteins that you won't notice or find just by sequencing DNA. And there are certain regions of DNA that are actually even more error-prone than that. So one of the things that, again, my colleague Stefan actually observed, which was quite interesting, and he was one of the first people to observe this, is that it appears that these errors that are just a natural part of RNA processing are much more common in cancer cells than they are in normal cells. And the reasons for this are not entirely clear, but the simplest explanation may be that generally cancer cells are much more transcriptionally active than normal cells are. And simply as a result of the amount of RNA that is being transcribed, the error rate is going to go up. So it's purely just a statistical game as a result of the large amount of transcription that these tumor cells are doing. So Stefan actually took a very, very interesting approach to finding these errors in RNA processing that result in these, potentially new protein antigens. And the way he did that was actually by designing a microchip that was printed with now about 400,000 individual proteins or peptides to which the immune system could respond. And this is basically every possible one of these unique error-born neoantigens that could be present. And then he actually looks for an immune response to these peptides in patients' serum. So it's very, very simple. So you take a drop of serum, put it on the chip, wash the chip a few times, and then add the drop of a second antibody that recognizes antibody bound to the chip with a fluorescent molecule on it. And then the pattern of fluorescence that the chip gives you when it's red is the pattern of peptides that individual person's antibodies are recognizing. And that can be a surrogate for, again, the neoantigens that are present in the tumors that these patients develop. So what you're seeing here is a heat map from some human cancer data, looking at prostate cancer, lung cancer, brain cancer, I don't remember what GC is, and breast cancer. So you can see each cancer has a somewhat unique pattern of reactivity with different antigens. And then to a degree, there may be some that are somewhat shared. So Stefan looked at this same kind of approach in mice, actually. So he looked for mice with tumors, looked at the patterns of peptides that they reacted to, and then actually used those peptides as vaccines in what are called challenge studies. So you vaccinate the mice, then you challenge them with cancer, and you can actually see that the mice that were challenged or that were vaccinated with one of the peptides that they were predicted to respond to based on this immune survey on the chip, actually there was significant prevention of tumor take in these mice. Then this is a separate study that actually used not a challenge model, but a model using genetically engineered mice that got breast cancer. And you can see a significant prolongation of survival in those mice that got a pooled vaccine consisting of 3 different neoantigens that he discovered. So subsequent to this work, there have actually been several other studies and actually pretty high-profile journals that have demonstrated this same phenomenon, that there are these neoantigens that are resulting in human cancer as a result of modulated or deranged RNA splicing and processing. So Stefan has done some of the same work using dog tumors. And actually, this is, again, 1, 2, 3, 4, 5, 7, 8 different kinds of canine cancer looking for these frame shift or these peptides derived from errors in RNA processing using this same kind of chip-based approach in serum. And again, what he was able to determine is there was a subset of these neoantigens consisting of about 28 or so different neoantigens that actually appeared to be conserved across these 8 major tumor types in dogs. And these are the peptides that actually form the basis for the vaccine that was tested in the VAX trial. And so in this trial, we enrolled 800 dogs across 3 different sites. And these dogs were randomized into 2 groups, either to receive the actual vaccine or a placebo vaccine that actually also consisted of a scrambled peptide and actually the same vaccine adjuvant. So these dogs were all between 5.5 and 11.5 years old, both mixed breeds and breeds that were considered to be at higher than average risk for cancer. And that risk was actually determined from the study that you see here that was published in 2011. So all these dogs had at least 3 years of medical records that we could review to make sure that they didn't have any history of prior cancer, prior autoimmune disease, and they were not currently undergoing treatment with any immunosuppressive drugs. All these dogs had a very thorough owner history and a thorough physical examination. Then they had lab work consisting of complete blood count, chemistry profile, urinalysis, and coagulation testing, chest x-rays, abdominal ultrasound. And I will mention that they also had fine needle aspirate cytology performed of any lump or bump that we could find on the outside of them. And then these dogs that qualified for the study, where they didn't have any other medical problems or any occult cancer, had an initial series of 4 every other week vaccines, and then yearly boosters of vaccines. They were checked every 6 months, and actually once a year, they also had repeat complete blood count chemistry and urinalysis to make sure that the vaccine was well tolerated. And then the owners actually received a financial incentive at the hospital for the treatment and diagnosis of any cancer that might be detected during the 5 years of the study. All of the routine care of these patients continued through the family veterinarian. So some of the outcomes that we sort of hypothesized about this study might be that, well, maybe cancer will be reduced. Maybe we will see a reduced incidence of cancer in those dogs who receive the vaccine. Maybe, like the genetically engineered mouse model, we don't see overall prevention of cancer, but we see a meaningful delay in the onset of cancer. So maybe instead of occurring at age 9.5, it occurs at 11 years old. And that would still be an incredibly important outcome, I think, if we can give dogs an extra 1 or 2 years of healthy life. Maybe some cancers are delayed or prevented, but others are not. This is something else that we'll be looking at. But there are certainly some advantages for the individual participants of the study. So one is that these participants are having twice yearly exams by an oncology specialist or professional, so that if they do develop cancer, there's maybe a higher likelihood that it's going to be early stage when it's diagnosed and treated at that early stage as well. And again, as I mentioned, there's a financial incentive for owners. And we have the potential to learn lots of other things as a result of following this group of 800 dogs for 5 years of their life. Obviously, we have some benefits that we think that are bigger than just the individual dogs in this study. So if in fact this study did suggest the delay or prevention of some tumors even, I think this would really provide very, very strong support for a similar kind of approach to be investigated in humans. And a veterinary version of this vaccine could be commercially available much sooner. So currently, again, the data, primary outcome data looking at the incidence of cancers in the hands of the statistician at this point. So I do not have information about that to share with you. However, there have been a couple of publications, and they're more ongoing, that are actually starting to come out using this cohort of patients. And I'll just share one of those with you. And this is a study that my colleague Jenna Burton was the first author on, that came out in JAVMA just late last year. And this is a study actually asking the question, what happens if you take almost 1,000 normal, apparently healthy, middle-aged to older dogs and screen them for cancer? So 913 dogs were assessed for eligibility, and 54 of those dogs actually ended up being excluded for either confirmed or possible neoplasia as a result of the screening that we performed. So again, that's 54 out of 913 dogs where we actually found something in our screening that made them ineligible because of possible cancer. You can see there's an equal number of dogs that were excluded for some other reason. But so what did we find during these screening tests? So in the 859 dogs where cancer was not detected, you can see, again, their age was maybe ever so slightly lower than those dogs that had either a definitive or a possible diagnosis of cancer. One of the things that we hypothesized is that maybe some of the at-risk breeds for cancer, like golden retrievers and Bernese Mountain Dogs, might have a higher incidence of occult cancer diagnosis than those other breeds, but in fact, that really was not the case. So what tumors did we find? I think this is actually the most interesting thing. So 16 of the 24 confirmed cancers that we found were either mast cell tumor, soft tissue sarcoma, or anal sac tumors. And then again, you could see a small number of other cancers. So why is that such an interesting finding and such an important finding, I think, for the general practitioner? All of those are tumor types that we were able to diagnose simply by performing a fine needle aspirate of a cutaneous or subcutaneous mass. None of these required blood work. None of these required imaging. So the simplest test that we can do, which is a good thorough physical exam and cytology of the cutaneous masses, we're able to diagnose the large majority of the tumors that we found in these dogs. There's another 30 dogs or so that had something that was suspected but couldn't be confirmed. And these included some pulmonary nodules, splenic nodules, adrenal masses, skin masses that we were unable to diagnose with cytology and that the owners declined further workup on, and then a few other things as well. Overall, again, in this group, we actually binned them into either a high, moderate, or low degree of suspicion for neoplasia based on the clinical presentation. And again, about 3/4 of these that were suspected were considered to be a moderate or low degree of suspicion for neoplasia. Once again, the method of detection. Most of the ones that were definitively diagnosed based on physical examination. And actually, very few of these patients were diagnosed based on imaging. So once again, I think that's potentially maybe the most interesting finding. So how often did we find cancer? So when you look at this as a frequency or as a prevalence, about 2.5% of the dogs that we screened had definitive evidence of cancer. And if you take those and add any suspicion of cancer on top of that, that number goes to be 5.9%. And again, there was no significant difference between the breeds that are considered to be at high risk for cancer and the mixed breed population. So I think that's actually a very interesting finding, and that's actually a significantly lower number that some of the other publications have used for sort of statistical inference. Some of the other publications have suggested maybe 10% of dogs at any time are walking around with undiagnosed cancer. In our situation, maybe it's more like 2.5 to 5%, depending on how you count them. So what are some of the other studies that are ongoing with this data set? So obviously, we're currently doing the primary efficacy and analysis of the immune response to the vaccine in our patients. I have a vet student, actually, Ray Amatia, who's got a draft of a paper looking at all of these dogs that we encounter in our practice that have small nodules that are detected by ultrasound. So what happens to those patients if we follow them for 5 years? How many of them turn into something that becomes a cause for concern? I think that's a very, very interesting and practical question that's being asked by Rhea. One of our interns, Dr. Caitlin Eliason, is working with Dr. Burton on a study looking at all the necropsy findings from our patients. So our necropsy compliance rate was very high in this study, about 70%. And we actually found anecdotally that there was a great difference between what was suspected to be the cause of death by owners or referring veterinarians in these patients and the actual confirmation that we observed in necropsy. So that, I think, is going to be a very, very interesting study that Dr. Eliason is getting started with. And then we have other investigators here who are very, very interested in two quite unique disease processes that seem to be present in humans and dogs. One of these is a disease called monoclonal gammopathy of undetermined significance, which appears to be sort of a precursor to multiple myeloma that never becomes multiple myeloma in most patients. And another disease called clonal hematopoiesis of indeterminate potential, which is actually a disease process that's been recognized in humans and now maybe in dogs as well, where leukemia mutations are actually detected in the DNA of dogs and humans, most of whom never go on to develop leukemia. So they have the mutations in their DNA and they never get cancer. So we're using this and other very, very large data sets to actually survey the frequency of both of these conditions in the patients that participated in this study, thanks to some work that's going on by some of our collaborators. And then we actually have another vaccine trial that's ongoing currently that is using a very, very similar frame shift-based vaccine approach, specifically as a therapeutic modality for the treatment of canine splenic hemangiosarcoma. And that is a study that's ongoing. That's another randomized, placebo-controlled prospective trial that seeks to enroll 60 dogs at 3 sites. And more than half of the dogs are enrolled in that study, and they're currently being followed. So I hope that this time next year, we may have some information about the outcome of this study that we will be able to report as well. And Dr. Johnston, who is now associated with a company called Calviri, has recently launched a cancer diagnostic actually based on this antibody chip-based technique that I mentioned for the diagnosis of early stage canine cancer. So again, if you did a Google search for Calviri, you will actually find information about this test, which is currently being launched in the state of Arizona in the United States. With that, again, I want to again thank our sponsors, thank all the members of the clinical trials team, as well as our collaborators around the United States who assisted, especially with the vaccine against canine cancer trial. And again, thank you very much for your attention. I hope this was informative. And I'm going to stop sharing my screen. So hopefully we may have maybe time for a question or two.
Thank you so much, Dr. Thamm. Can you hear me?
Yes, I can.
Oh, perfect. For your brilliant presentation. Now I will ask for the people here if anyone have questions for Dr. Thamm. We have researchers here, probably a lot of ideas in mind, right?
Yes. Hello, doctor. Are you listening?
Yes.
Yes, yes. I'm Chris. Okay. Your results about the losartan is very interesting, and I want to know, because this is a drug affordable for all of the clients, and do you think that your results could be different if you see a cold tumor microenvironment or a hot tumor microenvironment? In other words, can you predict the response looking for this phenotype of tumor microenvironment if you have some inflammatory cells patterns that describe this phenotype?
That's a very good question. And the answer is we don't know. So maybe if you have a cold tumor environment, maybe if you have a cold tumor environment, using losartan. Okay. Yeah. So maybe if you have a cold tumor environment, using losartan will help to make it less cold. Maybe if you already have a hot or hotter tumor microenvironment, losartan will make it even hotter. I think you could see how maybe it could help with either, but we really do not know. The other thing that I'll mention about losartan is currently we don't know if in dogs it has any effect when used alone. So in mice, it appears to have some effect when used alone. In dogs, we have only used it with palladium.
Hi, Dr. Thamm.
Hi, Dr. Dogley.
Hi, Dr. Thamm. This is Maria. How are you doing?
Very good. Thank you. Good to see you.
Good to see you. I have a practical question. In these clinical trials, how do you do? Do the owners pay for the dog's treatments, or you free everything for for example, the clinical tests? How do you do this?
Very good question. So for most of our studies, some things are paid for by the study, but not all. So we usually will expect owners to pay something for some of the care, and the study will pay a lot of it. One of the things that we learned is that when the study pays for everything, owners are not as invested, and maybe they will be less likely to comply. Maybe they will miss more appointments, maybe they will not show up. But if they have some financial investment, they are actually more likely to be compliant with the protocol. So it's very, very variable from study to study. So some studies might pay half, some studies might pay 90%. For many of the studies, we also have an incentive for the owners to do other forms of treatment when the study is over. So in addition to paying for the study, maybe there are some funds that the owner can use for care after the study also. So those two things help us to recruit owners to participate.
Right. Thank you. Thank you so much. Thank you for a brilliant lecture. Thank you.
Thank you.
For questions? Okay, Dr. Thamm, thank you so much again for your brilliant presentation for us. I'm sorry for you. You are losing our party.
I'm sorry too.
But probably we have another opportunity to receive here. And thank you for sharing the very nice results that you have in clinical trial. For sure, for everybody here, your results are very exciting for us too. And I think that's it. Thank you so much.
Excellent. Thank you so much. Good to see everyone. Bye-bye. Ciao.